So good morning, everyone. Welcome to the Brompton Virtual Grand Rounds. As you can see, I'm not Eric Lim. My name's Liana Ashrafian. I'm one of the consultants at Guy's and Tommy's, and I'm just standing in for Professor Lim today. It is my absolute pleasure to have with me Professor Calvin Ng from the Chinese University of Hong Kong to talk to us about a topic very close to my heart, expanding the diagnostic and therapeutic horizons for robotic bronchoscopy. As always, please do post any questions in the chat. We will have around 10 minutes at the end of the presentation to go through those. And we are very much looking forward to hearing your presentation, Professor. Thank you.
Thank you very much indeed for the kind introduction. It's always a pleasure to come back to the Brompton Grand Round. This is probably my third time coming back already, and I've been asked to talk about expanding diagnostic and therapeutic horizons with robotic assisted bronchoscopy. And this is what we're doing on a weekly basis. And it's a pleasure to share with you my thoughts. So why do we need some kind of navigation or advanced endobronchial therapeutic procedure? Certainly in my region of the world, we're seeing more and more small lesions, small GGOs, small nodules, patients who are getting screening, who have earlier diagnosis, and also patients living longer, even with pulmonary metastasis, who've gone through the multiple rounds of immunotherapy, chemotherapy, and they are just kind of stabilized in their disease and who may benefit from some kind of therapeutic local therapy to their lung with minimal trauma. So potential roles of robotic bronchoscopy, just I think everyone knows that for diagnostics, of course, you can do biopsy with it. You can also place fiducial markers for radiotherapy, for respiratory gated radiotherapy, sometimes requested by our RT oncology colleagues. Dye marking for surgery, we can go on for ages talking about how everyone does it and what the pros and the cons of putting dyes at different locations and so on. And to my heart also is local therapy, which is ablation. So with a platform like a robotic bronchoscope, you can take your tools and so on, therapeutic tools, etc., to the area that you want it to go to. So everyone's familiar with the systems, the robotic bronchoscopy systems. There's the Auris, there's the Ion, there's the Galaxy system. In our hospital, we have Auris Monarch, now acquired by J&J, and also the Galaxy system that has the digital tomography correction technology. We've started using that since 2023. There are other systems in development and also from mainland China as well, but much less popular globally. So any target in the lung is a problem to reach accurately, at least. One is that because the lesion is constantly moving, whether the patient's undergoing the procedure under some kind of very deep sedation or the patient's under general anesthetic, the patient needs to breathe at some time, at some point. And of course, the lesion will move according to that. There's also the problem with that almost all of these navigational systems, be it EMB or RAB systems, use a CT scan when the patient is done awake in respiratory breath hold. And therefore, the scan that we feed into the machine would be different from the day when we're going to be doing the operation when the patient is, for example, intubated during RAB procedure. And the mismatch in the navigational position from the CT scan and the intraoperative condition gives you this CT body divergence that you can see here. The planned procedure being this yellow-green area, and the actual airway that you're navigating is actually some way distant off. And if you're trying to target a 1 centimeter, 1.5 centimeter lesion, you can be off completely. So if you look at the data for robotic bronchoscopy biopsy in terms of its success in navigating to the lesion, most of the earlier papers were from the Monarch and Ion, Galaxy being a later system that came into play. And the cases were somewhere between 50 to 100 odd cases. Many of them use some kind of a virtual or real-time confirmation tool like a radio EBUS or even a cone beam CT to try to correct for this kind of CT body divergence. And you can see that on the right side, the diagnostic yield is around 75 to 85% using a whole host of different tools to get the biopsy. So it is probably an improvement from previous EMB systems if you look at it in that light. So most of the robotic bronchoscopy navigation systems use optical visualization and airway recognition, and they try to map the two using some kind of software, AI technology. A lot of the technology and the software matching this actually compensate for the movement during the respiration when the patient's intubated. They also use electromagnetic field to position and understand where your scope is, the length of scope inserted, shape sensing technology, particularly to one of the systems, and also the stability of the wires holding the scope in position and able to do the fine adjustments with your controller, giving you this accurate, quicker navigation to your target. But really, to come back to the point previously, is that to confirm navigation as well as, of course, biopsy success, you need some kind of real-time imaging like a radio EBUS or a digital tomography. And if you want to be more advanced with nicer 3D reconstructed images, then you need mobile CT or cone beam CT scan. And this just confirms that your tool, be it the ablation catheter or the biopsy tool, is in the lesion. But if you want to confirm that your lesion is in your tool, then you need like a ROSE, a frozen section, or one of these more fancy AI diagnostic machines like the Van Gogh machine in your OR. So one of the more latest RAB systems that use a sort of correction for this CT body divergence is the use of this digital tomography to correct for the navigational mismatch. So once you reach the lesion, actually, you can use a standard C-arm like you see here. And then, of course, once you are there, you do a 30-degree to 30-degree LAO, RAO spin. And so you can see there on the right side, the spin is basically done. And then after that, you will correct for the mismatch. So currently, the scope is not facing the lesion. So the blue circle is the real position of the lesion when the patient is under general anesthetic. And we're off by a little bit there, you can see. So we just need to adjust it. Just move your bullseye target across over the lesion. And under fluoroscopy, this is the real-time position of the lesion in the blue circle, and you're basically over your target. And with that, you can deploy your tool. In this particular case, if it's a biopsy, then you can deploy a needle into the target that you can see here, hopefully coming out. Sorry, the video is a bit slow to load. In your actual white light bronchoscopic view, you can see you're right up against lung parenchyma. You can't really see much. You can see the needle deployed into this real-time virtual blue circle, and you can do LAO, RAO shots to show that your tool is in lesion. And so you then can also do a digital tomo with a standard C-arm to show that your tool is indeed in the lesion. So hopefully you want this kind of image every time. So at least the first part of it, you know you've succeeded, i.e. tool in lesion. So with this kind of correction using imaging, you can probably get a diagnostic yield even higher towards the late 80s and early 90s. And in this kind of latest generation of robotic system, the MASH2 study and the Frontier study showed this kind of diagnostic yield under the strict criteria. And it is because of this kind of technology that the first author of this study said that this is probably one of the highest diagnostic yield studies since the development of robotic-assisted bronchoscopy. So moving on from diagnosis to treatment, we were thinking of local treatment, basically for patients with small lesions. And one of the things that we need to do is to look at the data that's available from our colleagues in radiology, the percutaneous ablation. So we did a sort of meta-analysis looking at SBRT versus thermal ablation. Most of this data is from percutaneous thermal ablation. And when you compare the data in this meta-analysis, it shows that primary lung cancer patients with small tumors had comparable outcomes after both of these treatments, and microwave may be a little bit better than radiofrequency ablation on the thermal side. And then when we looked at a similar meta-analysis for pulmonary metastasis between SBRT and thermal ablation, again, mostly from percutaneous approach, thermoablation actually had a slightly better local tumor control rate than SBRT, particularly at the later time points, and especially for some specific types of tumor metastasizing to the lungs, such as colorectal, renal cell carcinoma, and sarcoma metastasis. So with this kind of evidence and the ability now to navigate to the lesion, we first did our EMB using Super D, if I remember correctly, and an M-print microwave ablation catheter in treating a 83, 84-year-old patient with a left upper lobe adenocarcinoma of the lung back in March 2019. And you see at the top right, the CT scan. Pre-ablation, we didn't get it bullseye in the middle of the tumor with the ablation catheter, which is in the white spot there. But the result after the ablation was quite nice with coverage and a reasonable sort of margin as well. So we first did around our first 30 cases using this combination of technology and showed that there was no mortality, no early significant comorbidities. There was a 3% pneumothorax rate that was either observed or had a drainage catheter inserted, but everyone made it home, most of them within 1 to 2 days. And with that, it encouraged us to actually do the same procedure, not through a EMB, but through the RAB. And in 2022, we combined the two technologies in October to perform a ablation for a pulmonary metastasis back then. So in terms of transbronchial microwave ablation, which is the energy that we use the most, there have been several indications that we are using it for patients with primary lung cancer who are non-surgical candidates. Essentially, they have poor lung function, very poor comorbidities. Patients who have pulmonary metastasis, which is in the guidelines, as ablation is one of the things that one should consider versus the other types of local treatment. And also now more and more in highly selected cases, we're doing it for patients with multifocal lung cancer with GGOs that are small and progressing, patients who've had multiple surgery already for multifocal lung cancer, and they don't want any more surgery for these small GGOs. And we've had a few cases where we've been referred a patient with recurrences following radiotherapy as well, when they could not give any more radiation. In terms of selecting patients for this kind of thermoablation through the transbronchial route, through RAB, we are actually, over the last few years, selecting smaller and smaller lesions. At first, we were doing up to like 3 centimeters and then 2.5, and now probably almost like around 2 centimeters would result in a good ablation zone and good coverage. This is mostly because due to the limitation of the size of the ablation zone that the microwave catheter these days is able to create to cover the tumor. We also do the ablation in the middle and the outer third of the lung, and we try to omit the center third of the lung because it's very close to airways and blood vessels. And therefore, not only will there be heat sink effect, taking the heat away from the ablation, but also the fact that it's quite dangerous to access the tumor, sometimes having to go through large airways or hitting large blood vessels as well. So just some cases where we thought that indication is quite strong. This is a young patient who unfortunately a few years ago had a left pneumonectomy for a very central tumor, non-small cell lung carcinoma, but then 4 years later had a right upper lobe biopsy-proven squamous cell carcinoma of about 1.5 centimeters. We made the molecular analysis that makes sure that it's not like a recurrence from the left side, and so it's another primary, and we gave the patient the choice of radiation or ablation, and he chose ablation. So you can see here on the left side, catheter was put through the tumor, and the colored circle is the predicted ablation zone, and the right side is the ablation zone with the ablation change seen as a ground glass change. So this is also another example of a patient who's had previous hepatocellular carcinoma, who has pulmonary metastasis to the right upper lobe, quite small, again, sub-centimeter. And if we were to cut out these metastases, the patient will lose significant amount of lung function. After discussion, in fact, the patient was very keen to have ablation, and we were thinking that we could do a good job with ablation, with a good ablation margin as well, preserving lung function. Other cases to share, really, this is a preoperative CT scan on the left side of a metastasis quite near blood vessels in the right lower lobe. And the patient underwent ablation. You can see that the yellow circle was the position of the original tumor. The colored circle is the ablation zone. And 1 month and 3 months post-ablation CT scan showing the resolution of the distal atelectasis and the inflammation, contraction of the post-ablation area into a scar, and we expect that to shrink even more over the next 6 or 9 months. And we observe the scar just like the radiation oncologists use imaging to observe for any recurrence in the long term. Again, another metastasis from a colorectal cancer and the left lower lobe. And you can see here it's growing in size and becoming more dense over 1 to 2 months. We did a bracket ablation for this through the robotic bronchoscope. We placed the catheter individually one side and then ablation and then ablate the other side. And the right side is the 1 month CT scan that you can see there with a nice ablation zone with good margin. The tumor can be still clearly seen in the middle, and you can still see the 2 tracks that were where the position of the catheter used to be. So we also looked at our experience of ablation, of ablating multiple lesions in the same general anesthetic session to say whether it's safe or not. We presented this AATS 3 years ago of ablating up to between 2 to up to 4 lesions, nodules in one GA session. So we managed to do it all. Of course, ablating 4 lesions may take up to 4, 5, or 6 hours, depending on how difficult it is to navigate to and how good the response is. The minimum margin that we aim for all the lesions is 6 millimeters. Some margins, of course, would be larger in some areas. The hospital stay, when we compared patients who had multiple ablations versus a single ablation, was not significantly different, nor were the inflammatory markers. In terms of complications like pain, fever, pleural effusion, and hemoptysis, there was no difference between multiple nodule ablation to single nodule ablation group in terms of percentage, but pneumothorax was higher at around 8% versus 4% from the multi-nodule to the single nodular group. But however, if you divide the number of nodules per percent over the percentage of pneumothorax, every nodule in terms of percentage of pneumothorax that occurs is no higher than doing it in single individual sessions. So that makes sense because in every nodule, you're trying to not navigate to the lesion and deploy the tool, and that would, of course, potentially cause pneumothorax. So you can actually do multiple nodules, and that may be having important implications in pulmonary metastasis and multifocal lung cancer. It's technically feasible. The general anesthetic sessions are fewer. You may be able to save time in OT and also save costs, and it's basically safe. So far we've done over 300 thermal ablation using microwave, using either EMB or robotic bronchoscopy system, all successfully ablated over the last 6 years, with complication rate between 2 to 4% of bleeding, infection, effusion, and pneumothorax. The local recurrence rate at a median follow-up of around just under 3 years is 8%, and we've so far had no 30-day mortality or mortality related to ablation. And when you compare it to the SBRT local control rates, we are very on par with them or very similar to them. So in terms of multifocal lung cancer, just to give an example, this is a 40-year-old non-smoker, and her tumors resected from the right lower lobe and the right upper lobe through a segmentectomy and a lobectomy, shown molecularly to be different, and they had EGFR mutations, very typical in our region. But she still has 2 1-centimeter ground glass opacity in the left upper lobe and the left lower lobe, and she could have had wedge resections or sublobar resections, but she did not want any more resections. And they were persistent, growing very slowly, maybe 1 millimeter every year or 2 years, and SUV on PET scan was point something. So we thought we can do a very good job with ablation. You can see on the right side there. So a lot of the lesions in the either metastasis or multifocal lung cancer are in the very periphery of the lung. We also looked at the safety and feasibility of our cohort for microwave ablation for subpleural lung nodules less than 5 mm from the pleura, and we found that there's no significant difference in the safety outcome between subpleural and non-subpleural deeper lung nodules in terms of complications of pneumothorax effusion. So it's quite feasible to do them that are close to the pleura without significant harm to the patient. We also put together a review of how we manage using RAB ablation, multifocal lung cancer, published this year in Translational Lung Cancer Research. And in this workflow, you can see that for multiple lesions in low surgical risk category on the left side and high surgical risk category on the right side, eventually, as you filter down, in our practice, there is a room or there is an indication to do bronchoscopic ablation somewhere down the workflow of this particular paper. So we don't particularly want to compare ablation with surgery because they are different in terms of the margins that you can achieve and getting the pathology, et cetera, et cetera. But just a quick comparison is that, of course, ablation, you have a quicker recovery, short hospital stay, quicker back to work, and you can ablate bilateral lesions at the same time from multiple lobes. You preserve lung function and there's less bleeding, pain, and scar compared with surgery. So the last kind of a few slides of my talk is to look at other modalities of ablation, including other forms of thermal ablation. So there are now radiofrequency ablation is still available. The second generation uses a saline sort of oozing out infusion to propagate the effect of the thermal heat. You can have steam ablation and laser ablation, non-thermal, and some of them are immunogenic, including cryoablation, electroporation, and photodynamic therapy. They can all be done through the bronchoscope or RAB. Local drug treatment and injections, including standard chemotherapy, immunotherapy drugs, cytokines, CAR T cells, they're all in the works, as well as radio enhancers that we have access to as well, and the reemergence of brachytherapy, but local brachytherapy in the distal lung lesions by this company, Alpha Dart, of implanting these seeds into the tumor. So as I'm running out of time, this is the biggest and the only real study looking at the latest RFA ablation of over 100 patients, multi-center study with over 90% control published 2 years ago in Respirology. And this is the RFA ablation done in our hospital using the same system. This is a bracket ablation of a small GGO. You can see the post-ablation change here on my cursor that I'm drawing around the green circle around the yellow ground glass change. Cryoablation is also something which is being taken up. This is the world first publication in thorax 1 year ago, 2 years ago. Only 9 clinical cases, but enough to be published in this very prestigious journal because of its novelty. And the system uses liquid nitrogen to lower the temperature to minus 150 degrees Celsius. And you can see that after 1 ablation and after 2 ablation of this lesion marked as yellow, you can see a big ablation change around this nodule. And that's done, as you can see here, through a robotic bronchoscopy in our center. PEF as well is a non-thermal immunogenic ablations technology. We've done a treat and resect study showing that there creates a lot of immuno cell response, including tertiary lymphoid islands around the tumor. And also there are a number of studies that you can see here, preclinical studies, Insight ES, which is a treat and resect study, the Affinity study, and the Vigor study. Really have no time to go through each of these studies, looking at the evidence behind pulse electric field ablation, which is a non-thermal immunogenic ablation. So really, we have also done cases such as this with the PEF ablation with great success. And now they have a bigger ablation zone PEF system called the G20 system that does a 2 centimeter ablation zone. And we started doing that this year as well. AI, I believe, is also going to be important in the future for bronchoscopic ablation, in helping us to navigate to the lesion, for scope adjustment, catheter adjustment to optimize, in predicting ablation effects and assessing ablation effect. I think is going to be key because every patient is different, and assessing the recurrence based on the follow-up CT scans over the 1 to 2 years subsequent to the ablation. So in our center, we really hope with this technology to provide it for highly select patients, to tailor make their treatment plan, to allow them to have more choice, patient empowerment, so-called, and also to preserve their lung function in patients who have limited lung function or do not want their lung function further to deteriorate, and be able to treat lesions earlier in terms of metastasis or primary. So the take-home messages really are that lung cancer screening and use of CT scan is increasing, and particularly in my region, those with metastatic lung tumors are living longer, and the systemic treatments are prolonging their lives, and so local treatment may be more beneficial. RAB allows better access to different parts of the lung, including the peripheral, and in combination with imaging technology such as cone beam CT or digital tomography, it increases the accuracy of the deployment of your tool and improves the therapeutic workflow. There are many energy modalities apart from microwave that we're most familiar with, and with no probable single winner, depending on the clinical situation, we do need more data and experience. So thank you very much for your kind attention.
Thank you very much for an excellent presentation, an absolute whirlwind overview of robotic bronchoscopy and everything that goes with it. We've got a few questions in the Q&A, so we'll go through those. We've got a few minutes. The first one was about whether or not you have any weight and height restrictions. Does that constitute any limitations for robotic bronchoscopy and treatment?
Yeah, so for us, we have less consideration in terms of I think our consideration is that the patient may be too small, right, in my region, rather than usually too tall or with too high a BMI. With too high a BMI, we have had patients with a very tall chest that we have had to modify our setup a little bit so that the cone beam CT, when it rotates around the bed, does not impact on the patient or other equipment. And also the stickers that we put on to the patient for the EMB will be in the right place. And for those high BMI patients, we have to be very careful not to let atelectasis set in, obviously, with very stringent general anesthetic protocols that we have to ask our anesthesiologists to reinforce to avoid atelectasis. On the smaller patient side, we get 50 kg, 5'2" patients quite often. And of course, different bronchoscopes, robotic bronchoscopes have different sizes, and there may be some potential limitation to, how far you can reach distally with smaller airways in smaller habitus patients. So that's also a consideration. And the really small patients, sometimes we actually have to put a lot of bedding under them to lift them up so that the sticky pads that we put on them to allow the EMB localization is within the EMB field. Those are some of the things I've observed. Yeah.
Thank you. Yeah, certainly we've had that issue with the cone beam, with the CT in the very, very large patients. That is something to bear in mind. The next question is about a multifocal lung cancer. And how do you find that the robotic shape sensing technology compares with the EMB technologies? Is there a pro and con of either technology, do you think?
No, I think the shape sensing and the EMB technology for treating multifocal lung cancer, essentially the two technologies allow you to drive to the lesion accurately. So it's whether it's multifocal lung cancer or not that you're trying to treat, whether it's just biopsying one lesion or not, it's really the difference is the technology in driving to getting you there. So it's not so much the multifocal lung cancer, I think. The two technologies, I think you have to try out both technologies to see what fits your practice in terms of they do behave differently, the machines within the confines of a room, how big your room is, et cetera, and your associated technology that you have, the radio E-bus, as well as the imaging equipment that you have. So make sure that they are compatible within the confines of your room. And I would just suggest you go and test drive them, both, and see which, works best for you. To my knowledge, there's no clinical study or scientific evidence to say that one is better than the other in terms of being able to reach a particular lesion. So it's the verdict's still out. Yeah.
Thank you for that. Leading on from that, there's a question about whether or not you would ablate lymph nodes. Have you done any lymph node ablations for treatment of metastatic lymph node disease?
Yeah. So this is really at the borders, the horizon of what we can and may, or even should we even do it, sort of question. So people are ablating lymph nodes using PEF technology, so pulse electric field technology. That is very safe. It's just deploying a almost standard biopsy needle caliber tool into the lymph node to do the ablation through the bronchus, the proximal bronchi. And in the US, certainly people have been doing that in addition to ablating the primary tumor in order to have a local effect and an immunogenic effect with the pulse electric field. There is some talk that, of course, people are using cryoprobes to do biopsies of the mediastinal lymph nodes through their, radio E-bus and RAB systems. So potentially you can use that kind of probe to also not just to get a biopsy, but maybe to deploy some kind of cryoablative algorithm for some of those lymph nodes that you want to have destroyed. But that's really not mainstream right now, not for prime time right now. Yeah.
Thank you. And another question, how does the safety and efficacy of bronchoscopy technology compare with that for CT-guided percutaneous ablation when you're talking about ablating lung nodules?
Yeah, I think they behave very differently. Interestingly, we also do percutaneous ablation, and we can, have a real discussion about, which nodule would you choose to do a percutaneous, and which one would you approach through the bronchoscopic means. So I think the more obvious differences is that, of course, with the percutaneous, you have a high risk of pneumothorax. That's without doubt. So there's been some reviews or meta-analysis saying that percutaneous ablation, you will have a pleural-based complication like pneumothorax or bronchopleural fistula in somewhere between 22% to 50%, as high as that. Now, not every case, of course, needs a chest drain, but still, it is, a significant percentage of pleural complications. With a bronchoscopic approach, we have like 4 or 5% pneumothorax rate, so significantly lower. And in fact, we have just published a paper, I don't have time to present it, of bronchopleural fistula rate with bronchoscopic thermoablation of 1.9% that was published in ICVTS a few months ago. So again, it's lower. So why would we still choose percutaneous? Because percutaneous, sometimes we can put several needles at the same time into a tumor. So we can treat bigger tumors, like we've put 3 needles into a tumor to do cryoablation that can give you a big 5-centimeter ablation zone, 6-centimeter ablation zone. And so even with the disadvantage of pleural, injury, you can get bigger ablation zones and use different energies in a sort of synergistic way. And cryo, of course, is also good if your ablation or if your lesion is close to visceral structures because it's quite safe compared with thermal ablation. So many different reasons why we may occasionally choose percutaneous, but I think bronchoscopically we can do bilateral and lesions and 4 lesions in 4 different lobes, whereas percutaneous, I think even the bravest radiologists would not do that in the same go.
Yeah, absolutely. Another question about bilateral metastases or bilateral tumors. do you have a size and number limit when you're looking at bilateral disease?
Yes, I think our principle remains the same. When we were trained in, surgery, most people we're talking about 3 to 5 lesions for a colorectal metastasis, something like that, would be the kind of limit that one would do metastaectomy, using through traditional resection surgery. We still probably have that, but have that limit. But more and more, we are pushing the boundary a little bit more because of some patients we see are very well controlled with now, better systemic treatment, and some lesions remain quite stable, and we're able to treat 7 or 8 metastases in stages. So we, resect a few, and then we do the ablation of the smaller lesions in a separate setting. In some patients, we're able to do both the surgery and the ablation in the same general anesthetic session, depending on their, status and their comorbidities and their lung function. And just to minimize the lung trauma and minimize access trauma for the patient in whatever way we can to achieve the goal of local control. So that's our purpose, and we would discuss those in MDT.
Is there a lung function limitation that you would, like lower border of lung function, that you would be consider as an absolute red line, particularly for doing bilateral disease?
Yeah, I think ablation was described as one of the potential holy grail of, treating patients with very poor comorbidities and very poor lung function and so on. And I think people have found that when complications, for example, do occur when you have a bronchopleural fistula or when you have like an infective complication of the ablated area, if you do have very low lung function and therefore low reserve, then you really are more likely potentially to have a mortality even. Of course, there's been 1 or 2 mortalities reported in other countries with thermal ablation, including microwave ablation, and they have usually been for the more poor comorbidity patients with poor lung function. So when the complication does happen, then you have less reserve. But I think, 35, 40%, below that, one has to be a little bit careful of doing ablation, because when complications do occur, then you may have a significant morbidity or mortality on your hands. Yeah.
Thank you. And perhaps time for one more question, if that's all right. Have you had any experience of resection after ablation with patients with progressive disease, and how do you find that if you have had experience of it?
Yeah, so we have had experience of doing surgery after ablation for a nodule which is not at the ablation site, but on the same within the same thoracic cavity, and there's been some adhesions where we've done the ablation to the chest wall, but they can be easily taken down. We've also done surgery for unfortunate patients who we've ablated, but then had a local recurrence, and they are well enough to have surgery, although they didn't choose to have surgery in the first instance, and we resected that local recurrence for that patient as clinically indicated. I mean, if it's a systemic recurrence, we're not going to be doing that. But for a early discovered local recurrence, we can offer them this option. We've also offered them option of within our 8% recurrence rate, those patients, we offer them a reablation if we catch them early and we can still reach that area and reablate. And we have offered them surgery or radiotherapy. And in patients who have more extensive recurrences, particularly for metastatic lung disease, then they may need systemic treatment.
Fantastic. Thank you very much. I'm going to stop there just because we've massively run over time already. Thank you so much for an absolutely wonderful and insightful presentation. The number of questions clearly shows the appetite for this topic. So hopefully we'll have you back again at some point. Thank you very much.
Thank you for your invitation. Yes, thank you.
Bye-bye.
Bye-bye.